So, hello, everybody. Welcome. We're talking about treating anxiety disorders, an overview of DBT, CBT, and exposure and response prevention. I'm Dr. Arnoff. I'm going to be guiding you through today's topic. So, this is just a little bit about me. I am in the Hudson Valley area in New York, so a little bit upstate from New York City. I went to Boston University for college. I majored in deaf studies and psychology, so I do have a specialization in working with deaf and hard of hearing youth. And I still do that today. I went to Gallaudet University for my PhD in clinical psychology. And while I was there, I had the opportunity to train with so many amazing placements and hospitalizations and organizations. And so I'll go through them a little bit just to give you some insight into my training and what brings me to today's topic, because I have chosen to specialize in anxiety disorders primarily with adolescents and young adults. And so I've had a lot of exposure to different modalities of evidence based practice, three of which we'll cover in depth today. So during my third year, I had the opportunity to work at the Kenby Krieger Institute, which is part of Johns Hopkins in Baltimore. And I worked at a child and family therapy clinic, predominantly using functional family therapy. And then I had a full year of training at Children's National Medical Center in DC and Virginia, where I had training in exposure and response prevention. So we'll talk about that today. I worked at Mount Washington Pediatric Center and Newark Beth Israel Medical Center in New Jersey, focusing on CBT and trauma-focused cognitive behavioral therapy. And then in my experience as a pre-doc, postdoc fellow, and licensed psychologist at Astor Services for Children and Families back here in the like Poughkeepsie Rhinebeck area, I had a lot of training in DBT. And I had the opportunity to lead multiple young adult DBT groups. So we could talk about that. I can answer any questions about that. And now I have a private practice, again, where I specialize in adolescents and young adults with anxiety and depression, many of whom do have high risk ideation in terms of self harm. I push into schools to talk about suicide prevention and teen mental health, and I work within family court in Dutchess County. So I do a lot of different things in addition to these speaking engagements. So I'm so happy to have you all here. I am monitoring the chat as mentioned, so feel free to type in your questions as we go. And if it feels relevant to the slides at hand, then I will address them then. And we will have some time, prior to wrapping up to answer any last minute questions. So let's get started. Our learning objectives for today are to be able to describe therapeutic techniques used in evidence-based treatment of anxiety disorders. And while we're focusing on anxiety today, these modalities can also be applicable to depression, depressive disorders, trauma and stressor-based disorders, and obsessive and compulsive disorders. There's been some differences, which we'll cover in the change from our kind of big manual, the DSM-4 to the DSM-5, that pulled some things away from anxiety disorders into other diagnostic formulations, but they're still applicable. So we'll talk about those as well. The second is to be able to design effective treatment plans based on the client's presenting concerns. So looking at what they're coming in with, what their concerns are, what their abilities, maybe barriers to treatment might be, and determining which of the three modalities that we're talking about might be best fit for them. And then also discussing the application of these techniques with minors and their caregivers. So while I do specialize in young adults and adolescents, obviously I've carried a caseload over the last decade plus of my experience. So I am also working with individuals, in their 30s and entering into their 40s. So we will sort of describe different ways to apply the modalities, not just to the adult population, but to children and adolescents, as that has been my experience and my training over the last 15 years. So very excited to talk about that. So let's kind of ground ourselves in anxiety to start. Fear, when you think about it, is the response to a perceived threat. And so while anxiety involves worry about a threat that has not yet or may never happen. So fear encourages us to be on the lookout, remain aware, keeps us safe. It's an evolutionary trait that we have developed, right? Tune in with our surroundings. It's why we look both ways when we cross the street. It's why we're a little bit hesitant to hold our hands over something really hot or pull away if we feel that heat. It allows us to face challenges and achieve goals. It can be something that motivates us and, again, is helpful in some ways. But when we think of anxiety, we think of those racing thoughts, and that can prevent us from concentrating. And those worries about future and past can prevent us from living in the moment. So that's where mindfulness, which will come up in multiple modalities, is really important. Kind of focusing in on the now, really grounding yourself. And we will talk about different ways to do that, both with children and adolescents as well as the adult population. So, when we think about demographics and prevalence of anxiety, it is the most common mental health disorder in the United States. It affects 40 million adults. In 2022, which is some of the more recent CDC data, about 18% of American adults reported experiencing symptoms of anxiety within the last 2 weeks. And then from 2021 to 2022, 10% of children ages 3 to 17 years were diagnosed with anxiety. 26.6% of Americans aged 18 to 29 reported experiencing anxiety symptoms within those past 2 weeks, making this the adult age group most affected by anxiety. So I would say I'm kind of more often working in the middle of those two statistics. Typically, my clients are between 14 and 30, 14, 15, and 30. So it's prevalent. It's one of the most prevalent diagnoses. So it's really important and fantastic that there are so many evidence-based treatments that have been sort of tailored over time, we'll see over decades, to target, these symptoms in this population. So when we think of the DSM-5, which is kind of our holy manual for diagnostics, the anxiety disorders contain what you see here. Now, that is a little bit different than some of the things that had been placed in the DSM-4. So we'll talk about selective mutism in a moment as being, one of the only um, anxiety disorders that doesn't necessarily respond as well to like cognitive based interventions, mostly behavioral interventions, but everything else is going to be something that we can talk kind of directly to. If you have clients with these presenting concerns, there's going to be tools that can be utilized to address what is coming into the room during our presentation today. So some of the things that are missing are post-traumatic stress disorder, PTSD, and obsessive compulsive disorder, OCD. So I'm just going to go through those changes because, again, some of these, like when I was growing up in grad school, we were using the DSM-4. And so I was learning about anxiety disorders and its treatment, including PTSD and OCD. So I still think about applying these modalities to those diagnoses when they come into the room with me, even though they're technically not classified as anxiety disorders. So while the topic of today is anxiety disorders, I felt it was worthwhile to mention PTSD and OCD because they were previously classified as anxiety disorders. And a lot of what we're talking about today still is directly applicable to clients with those diagnoses. So when we think about PTSD classification, it was previously grouped with anxiety disorders, but a new category was created for the DSM-5 titled trauma and stressor related disorders. So that's where you might find it now. The change reflects a growing understanding that the diagnosis involves more than just anxiety, encompassing a broad range of emotional and behavioral responses to trauma. including additional symptoms such as negative appraisals of oneself, others, and the world, and pervasive negative emotional states. There's also the addition of this dissociative subtype, which for me is really important because many of my clients do experience depersonalization and derealization, which is not something that's talked about as commonly. There's not a ton of research on it. And so trying to figure out when a client is experiencing a dissociative state as a result of their anxiety, what tools and techniques might be most effective in treating them. This feels really helpful because at least by giving it a subtype or drawing attention to it, we're hopefully drawing funding and research toward that subtype so that we can learn a little bit more about it and develop some more evidence-based treatment for it. It can be treated through trauma-focused cognitive behavioral therapy, or TFCBT, as I mentioned earlier, and that's just combining cognitive and behavioral principles with exposures techniques, which is what we think about when we think of exposure and response prevention, or ERP, as I'll refer to it moving forward. With OCD, again, classified in the DSM-4 under anxiety disorders. Now it's in a new category titled obsessive compulsive and related disorders. The reclassification reflects this understanding that while OCD involves anxiety and distress, the core features, obsessions and compulsions, do differ from those of anxiety disorders. It also has some distinct neurobiological components with primary disruptions in serotonin versus dopamine and glutamate, which are found in most other anxiety disorders and in other anxiety disorders, not necessarily OCD. There's often heightened activity shown in the amygdala and limbic system. So it's functioning differently in the brain. There's different neurotransmitters that make it unique to other anxiety disorders. And for that reason, they did reclassify it in the DSM-5 as its own kind of category. So for the purposes of today's training, we're going to start with CBT, then we're going to lead into exposure and response prevention, and we're going to end with DBT. So that's the order in which we will cover it. Let's talk about the origins. Psychiatrist Dr. Aaron Beck, should sound familiar, developed cognitive therapy in the 1960s. So it was originally referred to simply as cognitive therapy, and he emphasized 3 areas of cognition, which we will explore in depth: automatic thoughts, cognitive distortion, and underlying beliefs. Although he originally noted the cognitive distortions in his clients as it pertained to their depression, the treatment has been found effective in outcome studies for various psychiatric disorders, including anxiety. Now it's considered first-line treatment for most anxiety disorders, as I mentioned earlier, with the exception of selective mutism, which behavioral interventions are prioritized. So as Dr. Beck's model, which did include cognitive, emotional, and behavioral components, and we can think of that like as the famous triangle, which I'll show you a picture of in a few slides, that modality was eventually referred to as cognitive behavioral therapy. So how is CBT structured? It's referred to as very didactic, very collaborative between therapist and client, and very goal-oriented. When I was being, trained as a grad student and as an early practicum student, I had constant and consistent exposure to CBT. I would say that's sort of the crux of my graduate school program. And then I had exposure to ERP and DBT through just like my training experiences. I was sort of hammered into me that CBT is time limited. So you hear constantly that like 12 to 20 sessions, it should be 12 to 20 sessions. And not only was that coming from my professors, but also from insurance companies. So if I was working in a hospital setting or in an outpatient treatment facility or a residential treatment facility, that was utilizing insurance, we had to sort of work within. And then I've also had experience sort of collaborating with insurance companies to have a little extra time to treat symptoms, but oftentimes they would only cover the 12 to 20 sessions. But it should be known, practically speaking, that the exact number of sessions can vary based on individual needs, the severity of the anxiety, and the specific approach used by the provider. I've been using CBT with some of my clients for years. Obviously, their symptoms have changed. Maybe they've taken breaks and come back, but I rarely find, and maybe that's just also a little bit my style, that 12 to 20 sessions is enough. The way that you can organize every session within CBT is starting with a mood check. How are you doing? I don't know if there's a way that you're tracking it. You could certainly do that. We'll go over thought records today, and there's a little graph that you can use. Review homework because there's always homework assigned with CBT. Um, Talk about the agenda for the day. Very organized, again, very collaborative. Focus on the problem, work through it for that day, assign homework for the next session, and do a summary. So here's that famous CBT triangle, right? Thoughts, feelings, behavior. And thoughts are on top, but really you could start it from any direction. Even just yesterday, I was talking with a client about um, like having movement be the thing. If they put themselves in that situation where they were moving, hopefully their thinking would follow. They could redirect their thinking and focus very mindfully on what they were doing, and then their feelings might be impacted. So it could be a start anywhere, but ultimately it's talking about how the thoughts that we have when we feel those emotions impact those emotions and how we feel them somatically. And as someone who does do a little bit of work within chronic pain, using pain reprocessing therapy. So that's a combination of CBT, exposure therapy, mindfulness based interventions. So some combination of those things. I do a lot of somatic work, including with kids, and we'll talk today about how you can start somatic integration even with kiddos in session, and that those things, thoughts and feelings, impact our behavior, how we respond to certain things, what we do we want to sort of avoid, do we want to numb out, do we want to redirect, and so how the interplay of those things is important for us to understand as providers, but also to provide psychoeducation for the clients on the existence of the famous three and the interaction between the famous three. Plus, this is just a cute, graphic. There's so many different versions of this that you could find, but kids respond, to cute, fun things. So let's break down the big three for cognitive therapy. So, Dr. Beck's focus. We'll start with automatic thoughts, a person's immediate, unpremeditated interpretation of events. We know they shape an individual's emotions and their actions in response to events. That's a callback right to the triangle, right? Dysfunctional automatic thoughts that are exaggerated or unrealistic are believed to play a significant role in psychopathology. These underlying beliefs shape the perception and interpretation of events. So they're impacted by our life experience. So they're different for everyone. That's where a little bit of that detective work comes in for each individual client, and understood as a template for information processing. So that's sort of the lens through which we process the information that we're receiving from other people. And these core beliefs are strong beliefs that an individual holds consistently over time about the world and themselves. And they tend to be rigid and overgeneralized. So I'm wondering, as I'm monitoring the chat, how many people have experience using CBT in their practice? So there's different types of cognitive distortions. Again, knowing about them as a provider can help sort of categorize them as you're conceptualizing a client, but also clients being aware of some of these things can allow them to sort of catch that information and those distortions as they're happening. Great. I'm seeing a lot of people using CBT most days, or a combination of CBT and DBT. I'm a big combo provider. I'm not using only one thing, because I've found some great bits and pieces from each individual modality that I've used. So let's talk a little bit about the more common cognitive distortions. So we have all or nothing or black and white thinking. So an example of that might be a client who says anything less than perfection is failure. And again, this is based on their life experiences, often as someone who works a lot with kids, and did my dissertation on parent-child dynamics. I'm thinking a lot about the attachment relationship, that early connection between caregiver and child, that's informing the lens through which we understand things, how we regulate internally, and how we interact with other people. So again, anything less than perfection is failure. Catastrophizing, if I don't pass this test, I will fail this class. And that comes up so often with my kiddos, regardless of, you know, middle school, high school, college, and then even my young adults who are working to pass an insurance program or become a realtor. That catastrophizing can be something that's very common. Then we have magnification and minimization. So getting a mediocre evaluation proves my inadequacy. They're sort of pulling information to sort of fulfill this lens through which they're viewing the world. Okay, well, my evaluation was mediocre. That is evidence to support my inadequacy. Getting high praise, that doesn't mean I'm smart. Just because I got the praise doesn't mean I'm smart, but the mediocre evaluation is proof of my inadequacy. So you're starting to see those distortions come to light. Mind reading, very popular. Okay, this person's being very quiet. They must be mad at me. It must be me that they're mad at, and that's impacting their response. And that taps in a little bit to personalization, which that's at the end. For example, the cashier was short with me because I did something. Not to open up the possibilities that there are other things that are going on with the cashier that could be impacting their mood and their behavior, but it's me that did something wrong. Then you have overgeneralization. That was a bad first date. I'm never gonna find someone. And so you see with cognitive distortions a lot, these absolute words, um, like always and never. And you wanna, I'm a big fan of metaphors, of using visualizations. As someone who's using American Sign Language in a lot of my sessions, my hands move and I have no control over them. So, I'll sort of show clients, this is always and this is never. But what about what's in between? We want to open their minds to that and have them consider those options as well. Just because this was a bad first date does not mean you will never find someone. So for someone who's saying, I don't use these, but I want to learn how to use them in my clinical work, you can provide them with evidence to the contrary. So, for example, if I don't pass this test, I'll fail the class. Okay, well, have you ever had an experience where you haven't passed a test before? Um, did you fail that class? No. So let's talk about the weight of this test on your overall class grade. Let's talk about opportunities for extra credit or a makeup or a redo. Let's talk about how we can best prepare you for the next test so that you perform better, so that it raises that grade. So there's no concern about failing the class. Also, are you going to fail the quarter? Does that mean you fail the year? Like, how far does their catastrophizing go? These distortions are just a great starting point for more questioning to get to those core beliefs and automatic thoughts. And then we get to be sort of detectives, collect evidence, and challenge clients. And I'm a big fan of challenging. Certainly not a quiet therapist. I don't think that's gets to be a style that I have anyway, working with teenagers. They wouldn't let me get away with that. So we're kind of going back and forth. So yeah, why is it that getting high praise doesn't mean you're smart, but getting a mediocre evaluation proves your inadequacy? See that you're kind of like only allowing one piece of evidence to confirm this thing, but you're not allowing this piece of evidence to confirm this belief. And for mind reading and personalization, you can remind them that, sure, that person is having an interaction with you in that moment, but also there were many people that came to the cashier before you that might have done something to frustrate them. Maybe they didn't have a good night's sleep. Maybe they're starving. Maybe they're really stressed about a test that they have that they're nervous about. There's so many things that could be impacting them, just like there are so many things that could be impacting us and our mood. And we talk about that too. So it doesn't necessarily mean they must be mad at you. You just happen to be a person receiving that frustration. So how can we self-soothe ourselves in the presence of someone who is frustrated if we know we're more likely to take something personally? So those are ways that you could sort of take these cognitive distortions and start conversations and lead to some, beneficial tips and techniques. The ones that we haven't discussed are mental filters. So a brief argument with a person overshadows the whole day, which was otherwise positive. That happens a lot with my clients. Just something that happened that wasn't positive per their report, per their description, that then leads to, oh, this day was horrible. If I ask how your day was, it was really bad. Um, Tell me what happened. This is what happened. And then I can, that's one incident in the whole day. And I might ask them to talk to me about earlier that day and what has happened since that day and what opportunities there are for the rest of the day to make it more positive. And when I was in grad school, I learned a technique and I still use it of like coloring in your day. And I don't know that this was initially tailored to children and adolescents, but my adult clients like it as well. But either on a planner or there are pictures that have sort of like squares that you can color in with a key being like this day I was happy, this day I was sad, this day I was angry, just sort of like an emotional tracker so that you have sort of your year in color. I like to specify it to day by day because that's a lot. It's a long process to sort of make a point and allow them to track it. I don't think that's also a bad idea. I think if they could do that too. But to like have a square or a circle or some shape that they color in every day or like use a highlighter or a pen or a symbol, it can be tailored to every client. To mark up what the day was like. So, what's the morning like overall, if you had to summarize it? What's the afternoon like, if you had to summarize it? What's the evening like? And more often than not, they'll notice that it's, yellow, blue, yellow. So, it was a good, positive morning. This thing happened that made me really sad. Or this thing happened that made me feel really purple anxious. And then it ended pretty well. So, relatively speaking, the whole day wasn't a bust. And it's just a visual for them to look at and to be faced with and to consider differently than these thoughts that are sort of on a reel in their heads that are also clouded by everything else that's going on in their brains. That's why I'm such a big fan of journaling and using some other, writing or art activities to get things off of the chest. Because I have seen in the chat there are some people who are somatic workers that will understand, as we all do, that when we carry that stress in our bodies, we feel it. We feel fatigued. We might get stomach aches. We might get headaches. That is heavy. So getting it out can really be helpful. So I find that that can be really helpful for mental filters. And then disqualifying the positive, same idea as minimization, downplaying personal strength, or attributing success to luck or other factors. Let's see here. Checking the chat. So, overgeneralization does tap into. I have a question that asks about the difference between all or nothing and overgeneralization. It is taking extreme thinking. So overgeneralization is taking that all or nothing extreme thinking and generalizing it to everything. So it's sort of that and like all or nothing plus or black or white thinking plus is overgeneralization. So with all or nothing or black and white thinking, we're talking about one specific incident. And with overgeneralization, we're thinking this all or nothing incident, like, oh, I didn't get a kiss on that date. Like, I'll never find a person. Like, I thought that day was okay. They didn't kiss me. I will never find happiness with a couple that is sort of like that all or nothing, and then saying, "Oh, that was a bad first date," versus, "Yeah, I will never find happiness." Does that make sense? Hopefully that clarifies things. You're sort of taking the all or nothing extremes. So this happened, so that means I will always be this version of myself, or in that situation, or never be this version of myself in that situation. And then the overgeneralization is taking that always or never thing and expanding it to in my whole life, this will apply to me now. Like, I'll never be able to be different than this all or nothing thing I've decided. So that's the sort of like plus of overgeneralization. Um, I will definitely talk on some tools that work for me in terms of journaling and other options. I have prompts for journaling in the slides. I also have an idea for blackout poetry if people don't like to write. Because a lot of my kids, they're coming from school or I see them on the weekend and they're done with work, which is where sort of like the homework aspect of cognitive behavioral therapy isn't as applicable. But we'll cover that as well. And then if we have time during the end Q&A, I'm happy to return to some of the case individuals that people are dropping in the chat, but I'm glad that we keep them. And I'm so happy to hear that people are already liking CBT if they have no experience with it. So let's talk a little bit about cognitive restructuring or reframing, as I like to put it. And that's noticing and building insight into that automatic thought. So again, we're breaking down these cognitive distortions. I'm catching them for clients. I'm pointing them out. Or maybe using a printout of this and trying to figure out which category of distortion their thinking falls into. So again, they're like really building insight into it. And that's part of that reframing work. And you can ask questions like, are there days or times this usually happens or never does? Are there thoughts you have when you're feeling this particular way that you hear playing over and over again, like a broken record? Like, what is the specific thought that you're having when you feel this way? So you're bringing it back to that triangle and trying to make connections. Don't be afraid to call them as you see them. So as a again, challenger, you have to sort of be ready and prepared to let a person know that this is coming up frequently as a pattern for them, even if they don't recognize it, and help them to face it a little bit. Maybe it's uncomfortable, or I don't know, there might be some barrier to why they're having difficulty catching it themselves or facing it, and you can work with them through that during treatment. But saying something like, it seems like this comes up a lot with you around X, but also challenging, like I've said with the catastrophizing example, if I don't pass this test, I'll fail the class. As a challenger, I'm going to say, well, that's not true. You've failed tests before and you haven't failed the class. Let's talk about that. Like, remind me of a time when you didn't perform well on this test and what happened after. Like, what were your options? Can we do things differently? Same idea. Can we get extra credit? Can you retake the test? Can you show up for like extra time with your teacher to show that you're committed to doing better? How can we prepare for next time? So you're sort of validating this concern because it was put there. They internalized that distortion from somewhere. They didn't just have this catastrophization. So you don't want to sort of blame them for having an automatic thought. We can't control those. So providing psychoeducation on that can be very validating for a client. I know that my clients are not asking to think this way. It's very disruptive and quite annoying and pretty frustrating for most of my clients to have distorted thinking. So being validating is very important, calling them out, reviewing the evidence, and then we come up with a challenge. So don't be afraid to call them as you see it. And five, evidence the contrary, as I've already been talking about. Develop and model those challenging statements and create challenge reminders for them to access between sessions. So again, they have internalized this distorted thinking, these core beliefs from other people. If they're not being faced with the reminders of the challenge, if we're not modeling the catching and the reframing and the challenge in session, and then reminding them in between sessions, which we need to figure out how to do that because I don't go home with them. They leave my office and that's it. I see them in a week. They need that external prompting. So I often have clients write those things down on a piece of paper, on a notebook that they have, on a notebook that I provide to them. I have sticky notes of every kind, color, shape they can put on their nightstand or on their door of their bedroom or on the mirror of their bathroom. They can carry with them in their backpack or their pocketbook to go to work, things that they're going to see all the time. I have them rewrite the prompt that is written when their alarm goes off. So the first thing that they see is a reminder of the challenge that they need to remember to push away those like negative core beliefs and automatic thoughts. So many ways to, some of my clients have recorded my voice saying the challenge so they get to carry a little Jamie with them in between sessions. Because again, it's going to be really hard for them not only just to catch that negative belief, but find evidence against it and challenge it all on their own and immediately. And you want to give them psychoeducation about all of this so they don't feel like they're not doing well enough or that they're failing if this doesn't happen overnight. This is the process of cognitive behavioral therapy. So, in theory, it should take 3 to 5 months to really take effect and internalize. So to give that information, I don't necessarily know that I would give the timestamp because it's different for everybody. But again, because they're coming in with these core beliefs, probably making an assumption that it's going to take them some time. They're not going to do this right away and generalize it to other clients. Like most of my clients take, time and figure it out with me in session and what works for them outside of sessions. Although we'll figure this out together. Maybe the idea that we use today to help you remember or face that information in session works. And maybe you feel like it really doesn't connect to you and we'll come up with something else. We're in this together. Very collaborative, right? So I think that's a really great option. This is a thought record for catching that information, keeping track of that information. It's from Judith Beck, Dr. Beck's daughter, also is big in the field of cognitive behavioral therapy. Very cool. She has written multiple books. This is her third edition book that's included in the references. And so there's lots of different handouts and worksheets that you can use in your sessions with your clients, pulled from that book, that resource. So it's just tracking a certain situation, what the automatic thoughts are, the emotions, adaptive responses. So what cognitive distortion did you make? Compose a response to the automatic thoughts, like what is the challenge? And then the outcome, how did you challenge it? How did it feel? What were you able to do? This sort of taps into the thinking, the feelings, and the behaviors, which again goes back to that CBT triangle. Which perfect timing, back to the triangle. So while cognitive restructuring or reframing helps us understand that connection between those thoughts and emotions, the behavioral activation shouldn't be forgotten. And it helps us understand how behaviors influence those emotions. So it can be as simple sometimes as changing the environment, and not everybody thinks about that. And I use descriptors and go through these days with my clients in detail and then suggest that they maybe even just move furniture in their room. If they feel like they're stuck in their room and their bed is the place that they go when they're feeling really anxious or really depressed, and that is sort of the space that they exist in when they feel that emotion, that piece of furniture sort of carries that emotion. Could you leave your bed and go to your chair in your office? Could you, like, make a little comfy fort on the floor and be on your computer or watch TV there? Could you leave your bed, and I'm not saying, like, take a shower, change your PJs, or do anything else. Can you go to another comfortable place that isn't the place you normally go when you're anxious and, like, get stuck there? Could you go down to a couch? Could you go to another bed in the house and, like, hang out there for a minute? Like, just leave the space, and sometimes getting some separation from that place gives just enough respite or clarity for them to reach for their evidence or challenge a distortion or use a self-soothing technique that they can use that is just like not included in that space. So, we want to work with them on getting all of their sort of ADL, the activities of daily living, like taking the shower, being mindful of hygiene, changing the pajamas, eating okay. But like when they're stuck in that place, especially with my high risk clients, like can a change in environment cause a pause in the thoughts and change the emotions if we're thinking about that triangle. Also, adding in enjoyable activities to their life. Make sure they're specific, realistic, and accomplishable. Um, but we want to, set them up for success. Make sure they're one at a time. Make sure it's something they could complete, something they do have access to. If you're working with kids, they might not have access to money or transportation, so be mindful of that. And problem solve barriers, anticipate setbacks, increase self compassion. That goes back to letting them know that this doesn't happen overnight, that this is work, and that it is frustrating, that they have these automatic thoughts, and help them build insight into what led to those automatic thoughts. Let them know they're not asking for these thoughts, that they're not conjuring them up themselves because that's what they want to be thinking. Um, and again, just like you want to build insight into what's leading to these negative experiences, same thing with success. What are days, times, and settings that you're most likely to succeed? And maybe we can focus on increasing the opportunity to be in those places, those settings, those experiences. And when they do succeed and make positive choices, reinforce those behaviors, praise them, even if it's something so small, even if it was something they were expected to do, make a big deal about that because, again, they're likely not internalizing that praise. They're not cheerleading themselves. We need to be that support for them. And so doing that every session is going to be a great model that hopefully they do internalize. Whether it's my voice, some of my clients will say, I hear you, like catch a thought and change it and challenge it in my everyday life. And eventually that voice that's mine becomes theirs. And maybe it never does. Maybe it's always me. And that's great. I love thinking about kids walking around with like a little Jamie cheerleader in their brains. Um, but it needs to be modeled so that it can be internalized. And then with things like the thought record, you want to track it and reflect it. And that's pretty consistent across all of the modalities we're going to talk about today. And when we get to DBT, we'll talk about diary cards as a great way to track and reflect. So when I think about somatic integration, I think it's important. I've already mentioned why. Obviously, I work with kids, so I wanted to talk about some child-friendly ways for somatic integration. If you are talking about how our bodies experience emotions and how the body responds and what cues we might get from our bodies that something's going wrong, like our foot tapping constantly or our legs shaking or our hands fidgeting or that stomach ache kind of feeling of nausea or those headaches or just like those aches and pains in the body that aren't from an injury or anything else. We have to be mindful this might be the first time that anyone's been asked to reflect on their feelings somatically, and they may not realize that physical symptoms could be connected to their emotions. So we want to be aware of that and provide some psychoeducation to that. But A, they might not have the words or language for it. B, they may not be at an age where they're like developmentally able to communicate in that way. Use a drawing, use a body drawing template. So I recommend if you're working with someone and asking them to do a body drawing template, you pull one out and do it with them so they don't feel weird or embarrassed. completing one while you just watch. Again, you're sort of modeling this behavior, you're normalizing this behavior. And I have crayons, colored pencils, and markers, and recommend the same because you want to be prepared for all visual and sensory preferences. Not all of my clients like the feel of crayons. Not all of my clients like sort of like the ink bleed of markers. So just being mindful of that and kind of keeping your toolkit full for every different client. So here's an example of a body drawing. So just a neutral body, just a great space for you to put down what it feels like. You can use words, you could use images, it could be whatever you want. There's no rules. Every kid can be different. Every client can be different, and they are. So for this example, they were just writing what it feels like for them to feel this anxiety in this situation. So they wrote that their ears felt really hot. That sometimes it felt like there was light, like flashes of light in front of their eyes, and that also kind of connected to feeling a headache, and that it was just like a cloud over their head. Um, their hands and feet got sweaty, and it felt like their stomach was all twisty and turny, and they had butterflies. And so it doesn't have to be much. The whole, paper doesn't have to be filled up. It could be one single thing, but it's them being mindful and connecting to their body, to that somatic experience, thinking about what it does feel like for them. So they're making that mind body connection, but it's also a good indicator for them later. I'm a knee bouncer. So people around me who know that I'm a knee bouncer will often catch my knee bounce as evidence that I'm stressed before I look stressed. I'm pretty good at regulating, but my body gives it away. I might be able to sort of like hide my thoughts. No one's a mind reader, but if my knee is bouncing, people are like, what's going on here? And so to let clients know that that might be something other people can tune into and that they can tune into might allow them to catch their anxiety earlier so that they can utilize tools and techniques sooner and hopefully prevent escalation, and also catch those thoughts without sort of the cloudiness of all of these other things, that they can hopefully collect that evidence and challenge it effectively. I'm seeing everybody talking about how what the population and age range they are working with. And it's great to see that so many different people have so many great experiences they're coming in with. So when I also think about child-friendly activities, but just anxiety in general, I think about tension, right? We're carrying tension in our bodies, providing psychoeducation about that. And that even though we might be aware that our bodies are sore, we may not be realizing when that tension increases and where in the body it's held. So for younger kids, I was taught really early on spaghetti. So you could talk to kids about if they've ever seen spaghetti being made or made spaghetti, and that like when spaghetti is raw and dry, it's like tall and rigid, like a stick figure, and that when it gets really hot, it's melts. It becomes kind of like this wiggly, ooey gooey thing. So to promote tension and release, like progressive muscle relaxation, which we'll talk about next. And I do have my favorite progressive muscle relaxation script for children and adolescents that you will receive separately as a part of this training. We'll go over it together, but you'll receive the actual script separately. This is just like a very intro portion of tension. So saying spaghetti and having everybody, no matter where they are, like shoulder to ears, tense their jaw, like hold in their stomach and be like a rigid spaghetti. And then once you say spaghetti again, you kind of like ooey gooey loosen up. So you're tensing and releasing. You're noticing what it feels like to have tension in your face, in your neck, in your shoulders, in your hands, in your legs, in your stomach. So when you're working with children and adolescents, it's important not to be afraid to be silly. And again, normalize the activity with them, do it with them so that you can see and they can see that it's not just this embarrassing therapy exercises. It's just like a fun activity that's promoting knowledge that's going to help them in the end. And also have family engage. If it is a child or adolescent, bring them in and teach them the skill that you learned today. Go through spaghetti so that the client, the younger client, feels less like the identified patient. Plus, if the family's involved, they can help prompt some of these things and catch some of these things in between sessions when they're not with you. So when you think of progressive muscle relaxation, I think of the mood, right? You want to set the tone, play relaxing music if that's helpful for them. Maybe they're a sound person, sound machine, waves, like a rainforest vibe. I have blankets in my office. All of my kids and clients take their shoes off when they're in my office and they're on my couch with their socks. Let's dim the lights. I have different versions of lights, both sort of like brighter and sort of more soothing, multicolored and just like a neutral colored that they can change into. I have one client that prefers to see me in the dark because she feels embarrassed talking about these things and has a really hard time making eye contact with people. So you really want to allow for sort of client preference, especially if you're trying to get them to relax. So here is a good photo review of the progressive muscle relaxation. Again, it's a fully written script that you can read directly from. You can have the client read directly from. This is child friendly, but I've done this with like my young adults and adult clients, and they like it too. So you have the lemons, you squeeze the lemons for tension in your hands and sort of your forearms. You stretch her arms up like a cat. Rest of your arms for your neck and your shoulders. You squish your face because there's a fly coming to your nose for facial tension. Chew in on this blob of bubble gum for jaw tension. You're laying in a forest and an elephant. You hear elephant stampede coming, and you got to tighten your abs to protect yourself from the elephant stampede. You squeeze a soccer ball between your legs for tension between your thighs, and then you either dig your toes into sand on the beach if that's their vibe and where they want to be, or into like mud and mud puddle. This can be tailored. This is, how I was raised in the field. I think my third year at Kennedy Krieger, someone exposed me to a version of this. I've tailored it a little bit. Like I changed it to a soccer ball because I have a lot of teenage boys that play soccer and I've got to relate to them. But I remember teaching it to my first teenager and having her be a person with anxiety, but that externalized and became irritability. And she got into a lot of, interpersonal conflict. And so she squeezed her lemon. She came in the next session and she was like, "Oh man, Miss Jamie, like I squeezed my lemons so hard and I will never forget that. And for that reason, I will never release this progressive muscle relaxation from my toolbox of techniques. It works. Kids love it. They don't have to say like, oh, I'm engaging in a progressive muscle relaxation. They could be like, I'm just squeezing my lemons. It doesn't feel like identified patient or client forward. It's just, they're making lemonade out of a tough situation. And so they love it. I love it. I'm such a big fan. I'm sharing it with all of you, and I hope you guys enjoy it. I have so much fun in session. Again, you can't be afraid to be silly. Like squeeze those lemons, like drop the lemons. Oh my god, the fly is coming to my nose. It flew away. Like the elephant's gone. Don't be afraid. You survived. Like, oh man, you're squeezing those. That was so good. You have to just be like a little bit silly, but also be, we're trying to relax them. So I've had some clients fall asleep during this process. So it really does. The point is to identify part of the body by part of the body, what it feels like to carry tension in that body, and then release that tension. So hopefully, by drawing their attention to it in a safe situation, they can decide and kind of catch as a signal that something is stressful or that they are building up their anxiety and need to intervene, whether that be cognitively or behaviorally, in the future. So if they're purposely doing this, a lot of my kids and clients fist up when they're getting stressed or anxious or angry. They might, like a cat, like their shoulders might raise, but they might not feel their shoulders raising. Their thigh might, bob up and down. Their stomachs might tense. They might have stomach aches. They might feel nauseous. So by bringing their attention to this tension and release in safe spaces, they're better able to identify it in other spaces where they might be able to intervene again more effectively. And once they notice it, they can use, like, if they are squeezing their hands and they notice it, they can be like, okay, I want to drop my lemons. And I'll squeeze them just to bring it back, and then I'll drop it again. I'll shake it out, and I'll make sure everything else feels loose, and then I'll go about my way. So, big fan of the progressive muscle relaxation script. These are some journal prompts. You want to help them identify automatic thoughts. So, asking them the prompt of what situation made me feel anxious today, what thoughts went through my mind at the time of that situation. I want to challenge those cognitive distortions. What's the evidence for and against this thought? Are there other ways to look at the situation? Again, we've got the extremes. What's in the middle? What are these other perspectives? What else could be going on for the people involved that have nothing to do with me? What would I say to a friend who's had the same thought? And we can use that skill a lot. Is there something that they would say, or certainly not say, which is more often the case, to a friend who was talking negatively about themselves, and sort of internalize that? Reframing and thought replacement. What's a more helpful or balanced way I could think about it? What would I do differently if this thought didn't control me? What did I do to feel safe? Did it help? Did it not? And increasing self-compassion and that perspective again. What do I need to hear right now to feel calmer? What would have been good for my partner or my family member to say to me in this moment that would have made it better? And what am I proud of myself for? Even if it was something little. Um, what does my anxiety protect me from? What might it be holding me back from? Just like building that insight, building that perspective, but also building that compassion. And the alternative to journaling. So, those are some prompts for people that were asking about prompts. For clients that are not into writing, I totally understand. They can voice note. I always tell them they could record a voice note. They don't have to handwrite it. They could type it if that feels better. They could draw it out with symbols and colors. We could have a code communication. They can show this to me. They never have to show it to me. It could be a great place to start a session. It could be a secret that they keep forever. They have options. But this blackout poetry is amazing. You take any already written piece of media, so magazines, books, newspapers, and you take a black, marker. Doesn't have to be black, could be any color that they want, and you black out the words you don't want, and you leave the words you do. You could leave all but, you could black out everything but one word. And it doesn't have to be a particular, like, type of media. It's just something that has writing on it. The point is to find the message that you want to leave, which is still you exploring how you're feeling and documenting it. But sometimes removing that personalization from it can make it much easier. So, same idea with what would you say to a friend like this? Not like, what do you need to hear? What would feel good for you? That can be really hard. But what would you say if a friend was struggling? Or this has nothing to do with you writing out what happened that day and how you were feeling, but maybe there's a word in here that you connect to, whether it allows you to lean into that feeling and process it, or move away from it so that you can organize it a little bit better. What does that look like? So this client left, I had been treading water, exploring the depths, following all the way down. It was a cold and lonely place. Then it occurred to me, such power. The sun sends a dazzling band of light across the sea, a shining sword in the water. Beautiful poetry. And what's amazing is that there's a community of Blackout poets. So if this is something that they really connect to, they can connect to other people who are also interested in this and utilizing this. They can go to Blackout Poetry jams. They can share their poetry if they want. So it's not only an opportunity and an alternative for journaling and for, like, emotional expression in a way that gives them some separation, that allows them to feel safe to do so, but it could be a great way for them to connect to other people who might be going through similar things, but who just have like a shared common interest. And we know how much extra support can be. So I love blackout poetry. I recommend it constantly. So we'll feel the same. So let's get into exposure and response prevention. ERP was pioneered in the 1960s by British psychologist Vic Meyer. So Dr. Edna Foa and her colleagues at UPenn further developed and named it in both the 1970s and the 1980s. So we're talking decades that these evidence-based treatments have been around. It is a widely recognized and effective treatment for OCD. So again, when you think about like over the last 10, 15 years, practitioners who sort of were raised in the field, going to graduate school at that time, being trained at that time, OCD was referred to as an anxiety disorder. But now that it's not, it still has been found effective to be a treatment for specific phobias, panic disorder, and PTSD. And I use it for all three of those things. Like CBT, its origins have been traced back to early psychology principles like behaviorism, classical and operating conditioning, as well as systematic desensitization. It's more than just facing your fears, it's facing those fears gradually and moderated with a practitioner, but also practicing resisting those habitual responses to those feels. So, namely, what we might refer to as a ritual or just avoidance. So, a ritual might be when we think about OCD in particular, like switching a light switch on and off, washing hands, if you're mindful about hygiene. But in general, I have clients who have a distressing thought and have to knock on wood or have to blink a certain number of times. Or if they see something with one side, like one eye, they have to sort of turn their head to see it with the other eye. Things have to be even, things have to be symmetrical. Those are those rituals that we're talking about. So when we think about specific phobias, we think about individuals who have an immediate and intense fear reaction to a situation or object that triggers them. We think about those somatic features, right? Heart rate increasing, muscles tensing. That's where PMR comes in, and breathing becomes fast and shallow. This can lead to panic attacks. So, a lot of individuals with panic disorder that includes more severe symptoms. It could be chest pain, full body shaking, and a sense of being disconnected from one's surroundings. So that brings us back to clients that might experience depersonalization or derealization, those dissociative subtypes. So, although someone with a phobia may realize that their intense fear is irrational, the person experiencing it for them, it's not any less real or less terrifying than if a serious threat were imminent. So we don't want to invalidate their the fear or the feeling that, like, despite knowing that that fear is irrational and that, like, likely the thing that they're worried about will not happen, we're still validating that those somatic experiences are very real. And people living with this type of anxiety disorder may not necessarily experience fear or anxiety in any other aspect of their life. So, what to know when we think about ERP? Since avoidance is a key feature of anxiety, this exposure type therapy can help those clients confront their fears because we're bringing them into contact with that feared object or situation in a safe environment. And it provides them with coping skills for when that triggering situation is presented, which allows them to use that skills to prevent that compulsion, those rituals, that avoidance from taking over. Hallmark of ERP is that it does not completely remove the distressing situations and thoughts. And I think this is sort of a through line for all three modalities or treatment in general for mental health diagnoses. I'm always going to tell a client that I can never promise to, like, eliminate the distressing thoughts and feelings that are bringing them into session, because as we've already talked about, anxiety and fear is sort of an evolutionary part of our predisposition of things that we consider. there's benefit to, like, sometimes being on edge and not knowing what's out there to keep us safe. So sometimes there is gonna be some anxiety, sometimes there is gonna be times when you feel, sad or angry in response to something, and so, again, we can't prevent those automatic thoughts from happening. What we can do is understand the origin of those thoughts, we can provide evidence against them, we can have practice with ERP in tolerating those distressing thoughts and feelings and behavior and feel more prepared to handle them and face them in the future, which just makes them less scary overall. So that's information that I will certainly provide a client pretty early on in our time together. So, as I just mentioned, not only can stress not be eliminated from someone's life altogether, but it would prevent them from being able to face those everyday situations in which these feelings are very real and very valid. So that psychoeducation can be really helpful, not just in setting them up for success, but providing psychoeducation about the pace and structure of ERP so that they don't fear things like flooding and can become really hesitant to engage. So flooding is sort of like facing your worst fear right away, and without sort of that gradualization. There's no desensitization. It's just like a flood of the fear. So letting them know in terms of structure and pace of treatment that it is going to be a collaborative process where we break down in the smallest increments we can what fears feel tolerable for them and what is sort of their worst possible fear, and how can we break those into um, realistic, small, accomplishable steps, even if we engage in the most tolerable thing for 60 seconds and then a minute and 5 minutes. This doesn't have to be, oh, for the next hour, you're going to have to face your worst fear. And sometimes when they hear exposure, they might have some preconceived notions, some misconceptions. So, in an effort to sort of keep client retention, to minimize that client resistance or hesitancy, providing that psychoeducation can be really helpful. So, exposure and response prevention is what ERP stands for. So, you're engaging in the exposure to the feared trigger or stimulus, and response prevention is allowing them to practice resisting those habitual responses to that fear. So, again, namely rituals and avoidance. So, you're preventing the inappropriate or disruptive response. Um, People typically get frustrated with themselves, and other people might get frustrated with them um, because they are like they have to stop what they're doing to do something else, potentially repeatedly, so that they can feel satisfied and soothed enough to continue on. So that is what ERP stands for. Again, for anybody that has thoughts or questions in the chat, I'm monitoring it. Feel free to type in your questions or thoughts as we go along. I will do my best to answer ones that are directly applicable as we go, and then they're doing a great job collecting the ones I don't get to for the end if we have time. So we've already done specific phobias. Coming back to flooding, because again, it is really important to differentiate. And we want to make sure we pace ourselves as providers. It can be scary to have, like, to force on a person's fears to themselves and like be the moderator for that. So for us, but also for the clients to recognize that it is um so collaborative, so step by step, and totally like within their control, within reason. Obviously, you're gonna have to push them a little bit. They might not choose to um, place themselves in a situation with a fear and stimulus, but a lot of people might be coming to you because you do have exposure with ERP and they are ready to put themselves in that position. So, as I mentioned before, flooding, another treatment for OCD, aims to make the obsession so bad, the fear so big, it overwhelms the nervous system in a way that it sort of resets and allows them to deal with their obsessions on their own. But that's not ERP. ERP is gradual, safe and controlled. It will become, as a gradual desensitization, more intensive. as these patients and clients do demonstrate an ability to handle their obsessive thoughts and urges, but we make that plan together, which I will show you in a little bit with ladders. Um, and we can go through some different case conceptualizations and client examples. So, just like CBT, I want to go over the treatment structure for ERP. After assessment, and at the end, we'll do a sort of summary and determine what, after the assessment, treatment might be most beneficial for a client. That therapist, the provider, will coach the client on confronting some of those triggering situations. And I think of it a little bit like PTSD treatment. So if I'm doing trauma focused cognitive behavioral therapy or TFCBT with the client, if they have complex trauma, which many of my clients do, we're not going to do it all at once on a single timeline, coming up with a single narrative for like the complexity of the trauma. We're going to pick particular events or incidents that were traumatic and face those individually. And once we feel like we have dealt with that in a manageable and tolerable way, we'll move on to the next one. So that's sort of how I might do that with a client with ERP. And during one of the works in progress ladders that I'll show you in a bit, I'll kind of go through how I'm going to parse it out because they sort of dump in all of their fears at once, but not all of them are related to one another. So this might include showing a patient pictures, playing videos, or even going outside of the office into the local community in some way. I live in Beacon, New York, so I'm sort of a town that has like a city vibe Main Street. It's fantastic. My office is one block off of Main Street. Most of my clients can walk to my office. It's a very walkable. They walk to school, they walk to work, they can walk to me. And so because we're one block away from Main Street, there's lots of opportunities for us to enter into the community together and supported. So if they're having a hard time making it outside of the house, they can come to my office. But then beyond that, a more triggering situation might be to like go out in public and order a coffee or order lunch and sit and eat that lunch. And so I have been able to accompany my clients to do all of these things just by nature of my comfort level with this treatment and the adults. Obviously, if you're working, I don't often do this with minors, but you'd want to make sure you have consent from the caregivers to sort of leave the office. Um, but typically this is done with my clients 18 and over. Um, and that's kind of a personal preference for you. I have the ability and the comfort level to do that, but not everybody does. But there are plenty of ways to engage in a gradual way clients with their triggering situations, even if they're not able to leave the office. Or for example, if I had a client who was afraid of flying, I'm not going to go with them to the airport or get on a plane. So there's other ways that we can do that. But yeah, the therapist will provide instructions and clear support on how to sort of resist those obsessions and redirect those compulsive behaviors. The client will work to envision the feared outcome on their own in the presence of the therapist and working to avoid completing their compulsive ritualistic behavior. And then, if you are comfortable with it, homework can be agreed upon. Again, depending on who they're living with, what their comfort level is, how ready they are to face that trigger without the support of a mental health provider present. But like with my minor clients who might have triggers existing in the home. So, for example, I have a client who has contamination OCD, and that's not contamination as you might think about it typically, which is hygiene contamination, so like germ contamination, where a lot of people might be very mindful of dirt and germs and washing their hands and taking precautions, wearing gloves, or doing certain rituals that make them feel better. This is contamination of their like self concept, their identity, and they have their biggest trigger is a twin sibling that up until they went to college, but even still, they lived with that person, they did activities with that person, they shared a friend group with that person. And so they were sort of going back into the home environment, which is a natural exposure for them. They are naturally every day having exposures. And so being mindful of that if and when you do assign homework, because you don't again want to flood them, especially when you're not there. But if you are thinking of homework, specifying, okay, well, you don't feel comfortable even really sharing air with this client. Perhaps the exposure at home could be you in the safety of your room, sending a text message to that sibling. And it could be a text message we predetermine in session. We could write it in session, so you just copy and paste it. It could be words, it could be an emoji, it could be whatever. But just being mindful of all of those things as you think about homework and are preparing them for natural exposures when they leave your office and go back into the environment. Someone asked, what do you think of using VR with this? I love that idea. One of the applications that I use a lot for sort of mindfulness-based intervention, self-soothing, and relaxation is Flowly, which is a virtual reality biofeedback application. I think I have on the top corner of my bookshelf, I have a Flowly, the goggles. You can use it just with your phone, but they do have like an immersive goggle thing. You can put your phone in the front of the goggles, and then it's fully sort of like your vision is blocked other than the virtual reality. I think that is an amazing way to move with them through some experiences and some exposures that previously we wouldn't have had the ability to do, like being at an airport or getting on a plane or watching a plane fly, things like that, but like being really in it. So I think VR is a great idea. And it seems like people who are in the research and development of products for anxiety disorders, which is one of the things Flowly was developed for, in addition to sort of chronic pain, are being mindful of because they're coming up with these different programs that clients can use for those right purposes. Yeah, someone made a point. Kids are so video game centric. That's why I'm so mindful of apps and phones, and why the challenges that I mentioned before with CBT, like having your background be a thought challenge, having the alarm words or text that goes off when your alarm goes off as like something motivating or something praising, or a challenge itself. I know a lot of my kids like will put a reminder in between their phone and their phone case if it's clear so they can see it and they're carrying it around with them. You know, we have to be mindful of who we're working with and what's going on with them, and phones are definitely what's going on with them. So that technology in general, VR, phones, video games, is certainly something that we can and, you know, sometimes should be integrating to meet our kids where they're at. I have lots of adults that love video games too, so kind of generalizable in that way as well. So there's three types of exposures that we've sort of already covered, but I'll put a label to the concept. So we have imaginal exposures, in vivo exposures, and interoceptive exposures. When I think of imaginal, we think of vividly imagining the feared object, situation, or activity that often cannot be easily confronted in real life. This helps habituate to a distressing internal imagery. So, for example, for clients that have health anxiety, a lot of my clients come in with health anxiety, they're imagining receiving a terminal diagnosis. That would be sort of the top of a ladder for some clients. For some, it could feel like middle or bottom of the ladder. And we'll go through, you know, what a hierarchy is, how to make it more accessible to younger populations. So using something like a ladder for the hierarchy. That would be something that we couldn't easily have them face in real life without it being a real ethical violation. So they're just imagining certain things. In vivo exposure is directly facing a feared object, situation, or activity. That's to reduce the avoidance. So for social anxiety, giving a speech in front of an audience, going to the coffee shop and ordering something, making a statement or advertising something at the local, you know, open mic, something like that. Interoceptive exposures is deliberately bringing on physical sensations that are harmless yet feared. And that's to break those learned associations between sensations and danger, because we can understand anxiety a lot of times as a false alarm. And when we are tuned in to our bodies, feeling like our heart is racing is an indication that we are in trouble, and thus the anxiety spirals, and either the rituals start or the avoidance initiates. And that's where using things like technology, as we're talking about, if someone has a Fitbit, or now Aura rings are so popular, or an Apple Watch, those things are tracking their heart rate, and they'll notice and even prompt sometimes, if the settings allow for it, to inform the person who's wearing it that there's been a spike. And so sometimes it can feel like the heart is racing, but when you look at it, your heart is actually racing. It's not racing at all. It's just beating as it typically would in a rest state. I do have one of those like heart rate monitors that I keep in the office to show them that if they do experience that symptom in session, which again, we're exposing them to scary things, it's likely that they are going to like enter into a stressful physical mode, to let them see like, oh, it feels like my heart's beating out of my chest, but it when I look at the number, it's not there. So it's sort of like CBT in a way, of taking that, catching that fear and challenging it and being like, okay, it feels like this, but I'm actually not in trouble for cardiac arrest. Like I don't need to go to the hospital to make sure I'm not dying. And it can get to that level. I have clients who feel like what's happening in their body is indication that they need to go to the emergency room. I'm seeing that some people in the chat are, getting prompts about their biological information. So exactly, we're literally wearing it. Why not use it? And then, so for this example, and I have lots, I did an entire year at Children's Medical training in ERP, and I still use it every week. So for panic disorder, running in place in order to increase heart rate, spinning a chair to create dizziness. There's different things that you can do to physically bring on those sensations that are feared, but when they like stop and are supported, they're like, okay, I feel this way, and that feeling is scary to me, and these are the learned associations that I have to this feeling, but I'm actually okay. Like if I sit with it for a minute, it's actually going to decrease, and the longer I do that, it's likely going to decrease in a way that I no longer notice it, or it actually fades away, at least for this moment. So I just need to sit with it for a minute, and that builds that experience with tolerance. So even if they're still afraid to engage in that situation, that activity, be around that object, they feel prepared to handle it because they know they can tolerate it. I tell them you're gonna still be uncomfortable at times in these situations. I cannot make that go away. And some clients do report that certain situations for them do become not just tolerable, but like fully engageable without that distress. But for the most part, like you're likely going to be uncomfortable when you interact with this thing, and you can tolerate it. So you do hard things all the time. You can do this thing for a minute, 5 minutes, 1 hour, however long you're going to need to do it. And we can get you there gradually and supportively. You might hear when you're working with ERP clinicians or with ERP treatment, SUDS, that stands for subjective units of discomfort. It's important that the client be able to distinguish those levels of anxiety when participating in ERP tasks, because we're asking them to tolerate those elevated levels of discomfort and stay with the experience until the discomfort decreases. So SUDS is often rated on an interval from 0 to 100, and that's just the extent of distress when completing an exposure. For minors, so my children and adolescents, but honestly, I'm usually using a fear thermometer or a ladder, which is scaled from 0 to 10, because it's just easier for them to wrap their minds around rather than like 0 to 100, and it still gets the point across. That provides them with a tool for ranking symptoms according to their difficulty when presented as targets for ERP, So 0 represents no anxiety, and 10 is the worst anxiety ever experienced. If you were to like Google or go online and look up like a SUD scale or a fear thermometer, there's many images for any age range and any need that you could utilize and access to sort of print out or have accessible to a client so that they can also have a visual representation when you're going over this information because you want to um, make sure we're catering to all learning dynamics. Not everybody is going to be like a text or an auditory learner. They might be a visual learner. And so I'm seeing somebody uses a 5-point scale for this. So yeah, just like it's subjective units of discomfort, it's subjective ways of visualization and communication to clients. And I see that some people are using SUDS for trauma therapy. Absolutely. As I mentioned before, a lot of these tools and techniques are going to be applicable to work, not just with anxiety disorders, um, but for work with trauma, with depression, with everything. I mean, it's why I think it's so important to learn about because you can integrate it into the work. So let's talk about the hierarchy. Once you've introduced this thermometer, it can be used to guide the creation of this hierarchy, of this ladder for gradual exposure. It's breaking that treatment into smaller, more manageable steps that, again, have this visual representation. It's done collaboratively, just like in CBT. So the client and the provider will construct the hierarchy in which the objects, the activities, and situations are ranked according to difficulty. So it's bottom to top. So beginning with mildly or moderately difficult exposures and then progressing to harder ones. And again, helps to track progress and reinforce success. So similar to CBT, it's a thought record, and similar to DBT, it's a diary card. So just different versions for the different modalities, but when we're thinking about it, they're still just tracking progress and reinforcing success. As triggers are mastered, as the number, right, on that thermometer decreases, the client then moves up the ladder. You're reinforcing effort, not just outcomes, because even if they try, they're still putting themselves in a really uncomfortable situation that they may have never tried to tolerate before. And that is worth praise. And if you don't praise them for that, I could imagine it's very hard to get motivation to continue climbing up the ladder. So we want to, arm them with that praise. And again, different from flooding, which begins with exposure to the most difficult tasks on the fear hierarchy. I like to start around 3 or 4 on the thermometer in terms of like if there's things that cause them no anxiety, maybe you could use that as like the foundation just to get them to do something and walk them through the process that gives them no fear. But the idea of the treatment is to expose them to a little bit of discomfort at first. So I would say like 0 to 2 is like a very manageable experiencing every day, tolerating just fine exposure. So maybe starting with a 3 or 4 on the thermometer is where I might start with the fear hierarchy. Obviously, we want to equip them with skills before we ask them to engage in these exposures. So we might do guided breathing. I have them focus on their breathing as it comes in and out, have them attend somatically to an area that feels most pleasant, comfortable, or even neutral, which might be their stomach, their chest, their nose. And we're just breathing. We're just breathing comfortably with a sense of ease. I'm not trying to do or change anything. We're having them just be really mindful in the moment and just enjoy the physical sensation of your breath while also giving their brains practice to attend to their bodies through a lens of safety. Because if they are individuals that do experience somatic manifestations of anxiety, which most of my clients do, or they're coming in with panic attacks or panic disorder, then they're very hyper aware and hypersensitive to these somatic experiences. And that somatic experience is going to lead to a flurry of anxious thoughts that's going to overwhelm them and cause them to avoid or engage in ritual. So having them practice attending inward and breathing through a part of the body that feels safe or neutral, it gives the body practice to do that. Um, Someone asks, is the thermometer standardized and available for use, or do you create a thermometer tailored to each client? It's basically standardized, like on a scale from 0 to 10. How do you feel? The the uniqueness is just in like the structure, the color, any imagery that you add to it. But it can just be like a basic like 0, no fear, 10, worst fear kind of thing. I also, especially if I'm working with clients that are younger, might use a calming bottle. So it's something for them to focus on that's not internal, that allows them to practice their deep breathing in a measured way. So you can take soap. I like to use soap that's kind of pearly, that allows for more of like a tornado center, add glitter, add food coloring, and so you just are doing a little bit of soap, however much glitter you want, and then a lot of water. You can also add miniatures, water beads. This can be used with sand, but when you spin it like this or shake it like this, it makes this little like tornado tunnel, and you can watch it spin. And the more soap you put in, the thicker obviously it gets. And if there's glitter or something else in it, it takes a longer for the glitter to stop spinning and settle. So this is almost used like a timer. So they shake it because they need to get that anxious energy out. And then they're watching the spin of the tornado like it might feel inside. That could be a good metaphor for them. If they're using a body drawing, for example, we're taking some of that CBT stuff and using it with ERP as well. And once it settles, they can check to see if they've settled. And if not, they can shake it again. So I'll play that one more time. So yeah, it's just like a really cool visual that they can use. So someone says, I was taught that when doing ERP, there should be no calming techniques used or any calming objects so they can really feel the fear and anxiety during the exposure. What are your thoughts? Absolutely. I am still going to equip them with um, the tools that they need before and after to prepare themselves, because if they're thinking about going into an exposure, that alone is an exposure that's increasing their number, on their thermometer. I say, like, what's your number? That's how I will prompt them. And so I want to make sure they're down to a 0 to 2 before I engage them in a 3, so that I can also accurately assess if the number they're giving it is truly the number they're experiencing. And then once they do tolerate the distressing object, I'm less focusing on you can't calm down, and more we don't want to engage in those like disruptive rituals or the avoidance. You can still like prompt soothing and calming and tolerance in the moment without engaging in those things. That for me is sort of like how I was taught to focus on um like what we do and don't do in the exposure. So there's a little bit of nuance to it, but I do think that equipping them before and as their number raises, and we end the exposure, there's always going to be time at the end you want to leave, because I don't want to get my client to a 7 or 8 and be like, see you next week. I want to bring them down to like a manageable number. We will engage back in breathing activities or do calming bottles or play a game or just talk about their favorite show or something like that. So that's sort of my thinking on that. No problem. So I have two case examples. So let's go through them quickly and then we'll have our next break. We've made it through ERP. This is a work in progress. This is for emetophobia. So the client is 23 years old, female, has a fear of vomiting, throwing up. In any case, like it breaks it down to the feeling of potentially bringing something into her body like a food or even a medication that could make her nauseous, that could prompt the feelings that feel like she might throw up or get her to a place, if there's like a side effect or a possible symptom of something that could lead to nausea or getting sick, seeing vomit, hearing throwing up, looking at throwing up, all of it. And that prevents her from doing a lot of things like eating foods she enjoys, taking medication when she needs it, participating in social events with friends or family, honestly, going out in public, being in a situation where she might be able to travel without access to a bathroom, or like a safe place to take a break if she's starting to panic or have a panic attack. So this is like our initial um ladder, our hierarchy. Um and I'll walk you like she just threw them out there. So one of the things she's afraid of, going to Rite Aid, leaving the house and going to Rite Aid doesn't feel safe. Because what if she starts to feel nauseous at the Rite Aid? What does she do? Um, Walking the circular driveway. That feels like something that's pretty easy for her, low on the ladder, because the circular driveway is her circular driveway right outside her front door. She can run back into the house if she doesn't feel good. So she could walk to the circular driveway, she could walk around the circular driveway, walking to it and back home feels easier than walking to and around it. She's prolonging the time she's out of her house in her safe space and back into her home. Driving to me, it's a couple of minutes, but it's a couple of minutes in a car. It's a couple minutes away from home. It's a couple minutes away from a bathroom. What if she doesn't feel good? What if it's too hot? The heat makes her body start to feel nauseous. Walking is easier than driving. Just making a point of it. Okay, when we're making it an actual ladder, which we'll show next with a different client, that's just a note that we wanted to put down. Going to the mall. That was something she really wanted to do. So for example, like the end goals for her were going to the mall, traveling to work in New York City, which is number 15. And we're trying to parse it out and break it up into little spots. So now you see numbers. So being at the mall, but outside of the mall is a 3 for her on a scale of 0 to 10. A 6 if she's stepping in the mall. So as we're like just typing out what things are scary, what things feel a little bit easier, like the circular driveway feels okay. Okay, well, does it feel better or worse to like go to the circular driveway versus walk around, like stay and walk around the driveway? For some clients, it might not. They might be one thing, but for her, it's 2. They have different numbers. Sitting down somewhere and eating, going to a carnival together. She mentioned the carnival. The carnival was coming up. I said, what's the carnival on a scale of 0 to 10? She said 25. So that's a big one. That's a hard one. Feeling dizzy is something she wanted to experience, but was too scared to experience. The sounds of vomit, visual vomit, those are, again, those versions of exposures we reviewed. You can, as hard as this might even feel and sound for us, imagine for her, like when I'm engaging in those exposures for emetophobia, like holding wet food in your mouth, like having the feeling of it and then spitting it out like you are throwing up. It's hard. This is not easy work. Not for them, not for us. But we're in it together. And again, one of her goals was like travel to work in New York City. She had been offered a job in New York City, and from where we live, take a train. So like getting on a train, and she had the goal by October, getting on a train and not just like sitting on the train and then jumping off the train, but like riding the train all the way into New York City, and that would be broken up into smaller pieces, and then get to New York City and get to work, like be able to travel to New York City for work. So these were kind of her goals. And that's how we like kind of start the hierarchy, use the thermometer to do a work in progress. So hopefully that gives an indication of just like what it might be like to sort of parse through these things. And someone had a great point, and I've used this as well. They bought their client a joke store plastic fake vomit to have near her. Absolutely great resource to use if you're sitting with emetophobia. So here's a completed ladder for a client that has panic attacks while driving. Starting at the bottom, thinking about taking a drive. So just the thinking about it, the imaginal exposure, walking to the driver's side of their car, sitting in the driver's seat with the car off, sitting there and turning the car on, driving at night, feels easier for them than driving during the day, making a left at that light. So there's a specific light and a specific road that I know that she has a hard time making a left at. And so we wanted to focus on that light because she needs to use it sometimes to get to and from work and other places for her. Driving, pre Fishkill in the underpass, driving on Route 9, which is a highway for us, and then driving on 84, which is a much bigger highway, 3 lanes, 65 over, 45 or 50. And even though a lot of people who live around here might say that driving on 84 is like the ultimate highway, she rated driving on the Taconic as very distressing, more distressing than driving on 84. I can understand that because it's not as well paved, it's not as well lit. There's animals like deer and stuff that are more likely to be on there. And then driving over the Newburgh Beacon Bridge, that is the most stressful experience that she's ever had. She hasn't been able to go to certain parts of town or visit certain people without having to take a much longer way because she will not drive over the Newbury Beacon Bridge. So that is sort of her goal. Let's see. I see a question here. I don't know if anybody has any questions about the ladder or the thermometer, but I see someone that asks, would you ever have her induce actual vomiting? My office mate brought tongue depressors and actually had the client throw up as a final task. I have not done that. But this client in particular has never thrown up. And that is one of the fears in that she doesn't know what it's like, and therefore it is so scary to her. I wouldn't personally, that not necessarily leans into flooding, but I wouldn't want to like over traumatize. We're just desensitizing a client. So for me, unless the client, like, I'd have to have a real discussion with the client. I guess I wouldn't say I would never do it, but I have never done it. And in the year of my training in ERP at Children's National, even if we had clients with emetophobia, we never induced vomiting. They got to, the top of their ladder and felt like they could tolerate it enough so that they could handle, everything else felt so much more managed that the fear of the vomit, like the phobia itself, decreased so much that we didn't feel it was necessary. But again, every clinician is different. Obviously, people who have had people induce vomit, and for them, it might have been something that they really discussed and decided was worth it. So I'm open to a conversation with the client about that, but that's not something I have ever done up until this point. So what is dialectical behavior therapy, or DBT? So psychologist Dr. Marshall Linehan developed DBT in the 1970s as a treatment for chronically suicidal individuals. It was first validated research-wise with women who met criteria for borderline personality disorder. So while it was validated for women who met criteria for BPD and sort of developed for chronically suicidal individuals, it can be really, really helpful in treating anxiety. Behavioral targets include stabilizing the client, obviously, if we're talking about suicidality, reducing therapy interfering behavior, so being late, not engaging, avoiding therapy altogether, and increasing skillful behavior, so giving them tools and techniques to manage their difficulties. It's been really helpful for me because a lot of my clients are high risk. So again, having urges or actively engaging in self-harm or experiencing suicidal ideation. For very strict DBT, you'll also have between session coaching, which promotes increased support for the client, especially during crises, as well as models interpersonal effectiveness, because you're having the opportunity to communicate with your coach in an effective way and get feedback if not. That is not something that I do in my private practice. I know some of my colleagues have, who I've grown up with in the field, do participate in like DBT clinics and do provide coaching. That is just not something I have the capability of doing in my work as a private practitioner. I'm only in the therapy office on Thursdays, Fridays, and Saturdays. And with the other work that I do, I'm just simply not accessible to my clients 24 hours a day for those individual coaching sessions. And then, in addition to having group therapy sessions or more task based, skillful behavior based sessions, individual therapy is more process oriented and focuses on solving current problems and motivational difficulties. So, in the clinics that I've been in prior to being in my private practice, um, leading DBT groups for young adults, so high school aged individuals, and then sort of college, early career age individuals. They participated in my DBT group, and then also had individual therapy, either with me or typically with another clinician, so that they had an opportunity for multiple perspectives and like multiple opportunities. So that's something that you could suggest or could provide within DBT. Again, as a private practice provider, I do not run groups at my practice. I'm only giving individual therapy. So while it is more process oriented, I also do the skills based work, but there are some local opportunities for individual and adolescent caregiver groups in my area. And we'll talk about the benefits of having family therapy if that works best for them. So, being a DBT provider, whether it's in a private practice or in a group practice that focuses solely on DBT, team consultation is another component of the treatment, and that's for the providers themselves. It focuses on fidelity to the manuals, and supporting providers working with those high risk clients, because that can be tough stuff. Um, so, as a facilitator of the young adult DBT group, I did that for 3 years. I both had experience as the co leader at first because I was new to the work, and then taking over as the leader. It could often be led by two individuals, two practitioners, one so that there is an opportunity to sort of learn and grow as a leader yourself as a provider, but also to sort of split the work into different sections to offer alternative perspectives, to sometimes maybe manage some processing that needs to be done when the other is focusing on the skills based work. And inherently, the modularity of DBT allows for skills to be added, modified, or deleted depending on the curriculum or need. So that's why I didn't choose to pursue a DBT only clinic as part of my work environment, but utilize it as a tool, as a modality in the work that I do as an individual therapist. So I wrote Franken Manual. I have it here. I call it my Franken Manual because as an individual who has led young adult DBT groups, I've had experience with both the adolescent manual by Rathis and Miller and the adult manual created by Linehan herself. And I found that for that age range, which is the age range that I continue to specialize in, some of the adolescent material feels condescending to them, and they're just not going to engage. They're not going to participate. They're going to avoid. They're going to resist participating. They're not going to come in. And sometimes the adult information is presented without a lightness that almost feels too abstract for anyone of any age to engage in. It doesn't feel as relatable as some of the young adult or adolescent manual like worksheets and handouts have. So they do, each manual does have handouts, which is more of the psychoeducation information of the skill of that day, and then the worksheets, which is more the homework that they're completing. And they're each getting a manual. They're using it in group or in session with you. They're bringing it home. They're responsible for bringing it back. That can be tough. I suppose you could keep it and like hand out worksheet by worksheet the information, and then keep their manuals at the clinic or at your private practice, depending on like what your space and resources is. But I basically took both manuals, printed them out, and then put them side by side and page by page pulled out the worksheets and the handouts that I felt to be most relatable and most effective just based on my experience using DBT with this population. And so I created a little Franken manual, which is a combination of both. So I laminated them and I bound them, and now I have a copy of these that my clients can utilize with me if we're using DBT as part of our treatment together. So it's a nice combination of the adolescent and adult manual together. When I think about DBT group therapy, it's well, I mentioned that skills training using those didactics and homework to learn replacement therapy for maladaptive behaviors. It's typically a commitment of a few months, and that's weekly opportunities to learn and practice. There are 4 modules, which we'll go into. And if you're doing a multifamily skills training group, which I have many clients that have participated in, it does depathologize, especially the adolescent, with caregivers recognizing their own needs to learn skills, identify their own maladaptive behaviors in an effort to decrease their contribution to family conflict as well. So, as I mentioned with the CBT, like opportunities to minimize the conceptualization of the adolescent or the minor as like the identified patient, I think is really important. Also, when caretakers learn the skills, they can serve as skills coaches between sessions. So, the 4 modules of DBT are mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. So, mindfulness is working to observe and describe your thinking wholly and not judgmentally. Distress tolerance focuses on acceptance, finding meaning, and tolerating distress. So, again, we're starting to see commonalities across all 3 of these modalities, right? It's different from available behavior treatment at the time, which focused on changing behavior, not accepting what was happening, not finding meaning in what was happening, and not tolerating it. So, we're not necessarily asking them to judge it and change it. We're asking them to see it, find meaning in what's happening, and work to accept what's out of their control and respond effectively, especially interpersonally. But with emotional regulation, reducing those unwanted emotional responses and increasing desired emotions. So I have mentioned the DBT diary card throughout today's presentation, and I'll show you an image of an example in a minute, but it is a tracking system, much like the thought record, much like a hierarchy or a ladder in CBT and ERP. So with DBT, it allows to track client triggers, emotions, behaviors, and use of DBT skills between sessions. It's originally created to track sort of those high risk thoughts and urges, so urges to self harm, suicidal ideation. And it is used to promote insight and facilitate skill refinement. It also allows for routine monitoring by the provider at the start of every session, which I think is critical for intervention, especially when suicide urges are high. When it's something that you're integrating into your sessions, I think it's really important to problem solve barriers to completion. Like, what, before you even send them home with it, what is the expectation of completing it? Have blank copies to be completed collaboratively in session if they don't. But, printing it out, sending it to them electronically. So again, it's coming to their phone or their computer. We're utilizing technology. I sometimes suggest that clients complete it like right after something has happened if they can, but they're not always in a place where A, their diary card is accessible, or B, they feel safe in a confidential private space to complete it. You don't have to use words. You can use stickers, you can use colors, you can use symbols to indicate whether or not you had an urge. Did it work? What did you do? Again, very tailored to every client based on the circumstances that they are in when they're at home and how safe they feel like documenting that information. And you are asking them to bring it in. So if they can't document it right after the session or the incident happens, maybe it's something that they do right before bed and they leave it on their nightstand. Maybe it's something they do when they start the day. So they've like had time to sort of like process and recover from the day prior. Then they can look back and review it and go through the incident that occurred with some more clarity. So there's lots of ways to do it. problem solve those barriers, work with them to minimize those barriers. And if they forget, say, don't worry, I have a blank copy right here. Let's complete it together. And you complete it together because, again, you're using this not just to track what's going on for them, but to promote insight for them to recognize what situations might be causing this urge to, rise up as opposed to other circumstances when you're feeling more at ease or more regulated. What skills did you use? Did they work? Did they not? Like, how are you feeling? What kinds of things prompt these thoughts and urges? So this is what a diary card might look like. You put the day of that session. So for today, we're together on August 22nd, and then every day for another week. I require my high-risk clients to see me every week. So I just put out the week, and we're talking about NSSI, or non-suicidal self-injury. I split it up into urgent action. We're trying to build insight into emotions with this particular client, and we're talking about skills. You can add emotional intensity and effectiveness or reflective columns. If you go online and look up diary cards, there are some with dozens of columns. That, for me, especially for my younger clients, is really overwhelming, unrealistic to expect that they complete that information. And again, I don't necessarily align with that as like a small, realistic, and manageable goal. So I'm going to break it down into something very specific. Today, we're doing emotions. I'll add skills as like an added bonus, but we're really just tracking the urge and action and what you were feeling in those moments as a jump board to not just track it, but to start conversation about it. So that's an example of a diary card. Some people might hear dialectic and wonder what that means. So we break it down for them. There's always more than one way to think about a situation and more than one way to solve a problem. So just like the black and white thinking, the always and never, the perspective taking, we want to consider more than one side, right? There's both and. Everyone's unique in their own ways. They have different perspectives, and we can work to help clients accept that different opinions can be valid, even if you don't agree. Like, agreement does not mean acceptance. That's a big image on handouts in the manuals, like the equal sign with a slash through it. Just because you're accepting it does not mean you're agreeing with it. But perhaps it's most effective in that moment based on your needs to accept and move forward in that moment. Or how can we communicate effectively that you disagree in a way that you can both move forward together? Two opposite ideas can be true at the same time. It, again, helps move away from that distorted thinking. And it doesn't mean you're surrendering your values, just understanding multiple truths. So, for example, we've been getting a lot of rain here lately. It can be a sunny day and rain. Like, you can have opposing ideas that occur at the same time. You can have a sun shower. So how do you guide clients through this idea, through this treatment? Instead of either or, you say both and. So I work really hard to take clients' language of this happened, but this happened. That's what it invalidates what happened before. So this happened and this happened. And they do catch themselves. They'll catch themselves just like they catch distorted thoughts. I'll be like, but wait, let's reframe. Let's say and here are some examples. I can do this and it's going to be hard. Or you can flip that, right? This is going to be really hard and I can do it. For a client who has cognitive distortions about like failing a test, failing a class, like it will be hard to pass the next test and I can do it. I can be an independent person if that's really important to me, and I can want help. That doesn't take away from my independence. Both things can be true. I may have a valid reason for believing what I do, and in this scenario, I may still be wrong. If we're talking about minors, right, and we're working with families, I have a parent who's very rigid and really cares about me. Just because they're rigid doesn't mean they don't care about me. Again, avoiding absolute thinking, taking away words like always and never, checking mind reading assumptions. So again, we're seeing this intermingling of CBT and DBT. No more assuming that we know what other people are thinking. If they say something like that, I'll be like, oh my gosh, did you figure out mind reading? Write the book because I have not mastered that skill and I would love to know what's going on in your brain when you're sitting on my couch. And, you make light of it. They'll laugh and be like, yeah, yeah, whatever. I can open myself up to other perspectives and accept that, I was doing me in that moment and that what they were doing had nothing to do with me. And no expectations that others know what you're thinking. So sometimes people get really upset or frustrated or anxious because other individuals are not acting in a situation the way that would make them feel more comfortable or more safe or more able to participate. But they're not communicating to those people that in that moment they are feeling overwhelmed or they are in distress. And so we can't assume that they know what's going on. They could be masters of masking and hiding. A lot of my clients are. And so we have to remind them that there's no expectations that others know what we're thinking. And that's where interpersonal effectiveness comes in because it's sharing effectively what's going on for us and what we might need to best get through the situation with other people. So I'm going to go through each of the modules and just give you a few of my favorite activities. Some of them are child friendly, all of them are generalized to other populations. Um, Obviously, as this is an overview training, we have got an overview of CBT with some of my favorite activities, ERP with versions of my hierarchy, my ladder. And so this is just on the surface level of some of my favorite activities for these modules. So when I think of mindfulness, I think it's applicable across all anxiety disorders. It helps you slow down, notice your emotions, your thoughts, your urges, and in an effort to modify behavior more thoughtfully rather than impulsively. Um, when your mind starts to drift, you're just concentrating on that, you're refocusing that, you're noticing it, but you're not judging it. That's a big part of DBT. You're not being judgmental. And so I'll kind of walk through very quickly these activities. The coin sauce is having a collection of the same kind of coins. So let's say a bunch of dimes, all different, can be done with a client, can be done in a group, and you dump the dimes on a table or on the pillow, on the couch, on a blanket, whatever. And you just like grab a coin, and you take 60 seconds to look at the coin. And the point is to really look at the coin. Like, is the coin? Who is on the coin? What year is the coin? Are there any nuances or tarnishes or varnishes or dents on the side? Have you paid attention to the difference in color from the front of a coin to the side of the coin and like that the divots are in the middle? Really looking at something. Same idea with mindful eating. You're holding something like a piece of candy or a Hershey Kiss and you're staring at it. You're looking at the outside, then peeling it back, seeing the difference between the texture of the outside shell and like the smoothness of the covering. Does your little tip, does it exist? Is it cracked off? Feeling the difference in feeling between like the flag and the covering, feeling it, watching it melt, letting it sit on your tongue. Same idea with the coin toss. You're paying attention to it. You're noticing if your mind's starting to drift, but you don't judge it. You bring it back and you dump all the coins back in, you mix them up, and then you have 60 seconds to find your own coin to see how mindful you're really being. Inside outside sounds is just as it says, pay attention to sounds inside the room and sounds outside of the room. An ABC game or a never ending story are starting with the letters of the alphabet for ABCs, coming up with a category and alternating. So I usually start with animals. So the first person will say aardvark, bunny, cat, dog. You can skip, you can pass. Some of the letters are really hard or impossible. So it becomes kind of lighthearted and fun, which is sort of the point of a lot of these coping skills. We're not trying to make them therapy exercises. Anyone of any age is going to sort of like away from that. These are just games. It is a mindfulness game, but this is something that you could do the ABC game quietly in your own mind or play with other people, a partner, a family member, your friends. It doesn't have to be therapeutic, even though it actually is. And then the never ending story is you either say a word or a sentence and then alternate, and you end up compiling the story that has twists and turns and plots you never saw coming and end up being really funny and again make you feel less like the identified patient and more just like you're engaging in something that's holding your attention and redirecting it from a distressing thought or distressing emotion. And scribble art, same idea. You're just using a marker or a crayon or a colored pencil, and you're starting with a line in your color, and then you pass the paper to the next person, and they make another line, and everybody kind of has an idea of what image they have in their mind, and it never ends up like that, and it ends up being like a rainbow, funny looking penguin, which leads to laughs and lightness. And then you have this like great visualization that you can print out of something that you guys did together that was fun and lighthearted, and a reminder that interpersonal engagement can be positive, especially if there's existing conflict within that interpersonal dynamic. For distress tolerance, I think of pros and cons. I feel like as an individual, I remember away from therapy being raised with like, okay, this is a decision you have to make. What are the pros and cons? But when I got to DBT, I liked how they expanded upon that into 4 categories, not just 2. So if we're thinking about acting on the crisis urges versus resisting crisis urges, we're going to do both. The pros of acting on those impulses, so the pros of giving in versus the cons of acting on those impulses and cons of giving in versus the pros of resisting impulses and not giving up and the cons of resisting impulses and not giving up. I think it just expands the consideration to the nth degree. It builds insight. It allows for a depth of conversation that gets to things that might not have come up if you only did like, what's the pros and cons of doing this thing, not resisting the impulses, which in sometimes is the healthier, more effective thing to do. My favorite thing from distress tolerance, which I use with all of my clients, regardless of the modality that I am prioritizing, if they have depression, anxiety, trauma, they're coming in, they're making a self-soothing kit with me. So self-soothing is a major tenet of distress tolerance and DBT, and that you break it down through the 5 senses. So just in an effort to engage clients in the activity before we actually do anything, I like to give them the opportunity to share what they do to feel better when they don't feel great, and understand that those things typically fall within the 5 senses, and see if they already prioritize 2 or 3. They tend not to have like just one, and they tend to use a little bit of everything, but I might give them, free response prompts to let them just tell me, and then I might prompt them through to see and pull out a little bit more information about which of the 5 senses they're using. Are they a person who uses sight, taking and looking at pictures, engaging in social media? Are they a lights person? Do they have dimmers? Do they have LED lights around their room? How do they like to have lights on in my room? Making a space in their room that's pleasing to look at, helping them work with that if they're a sight person. Or are they a sound person? They have certain playlists, type them up to lean into emotion. Do they need sound machines to fall asleep? Do they really enjoy instruments, like going to concerts or playing instruments as a form of self-soothing? Touch. Do they like soft materials? Do they have comfortable clothes they put on their body when they're feeling a little panicky or right when they come home from school or home from work? Are they a temperature person? A lot of my clients are big into really hot or really cold showers as a way to just pause what's going on for them, shock their system, relax into their system. Are they a blanket burrito? Like, do they like to be wrapped up in blankets and like kind of swaddled? Um, Regardless of their age, and smell and taste, sort of a little bit of similar things. Are they endorsing flowers or a favorite soap, smelling a familiar food, having scented candles? And I'm always equipped in my office with all kinds of candy. You got to be mindful of allergies. I always ask the clients and their caregivers if they have specific allergies, because if it's a minor and they want something and they know they're not allowed to have it, then they might lie. So you got to check just to make sure. But having something that's chocolatey, having something that's spicy or like cinnamony, like a red hot or a fireball or sour. I have crybabies and warheads and things like that. And with smell and taste, it can be nostalgia. That's the soothing part of it. So a recipe that they can either make or someone else can make for them that reminds them of a person that was really comforting or a time that was really comforting. Someone added Sour Patch Kids, absolutely. Um, I try and find things that are, like, individually wrapped, and now they're making, like, bigger Sour Patch Kids, so you can often find those individually wrapped, but a lot of those candies just, like, come in a bag, and, like, I'm just not gonna be, like, handing out like, having my kids put their hands in a bag, and grab them, so anything I can find that's individually wrapped is a great snack for the office, and again, as we're building utilizing these senses, we're wanting to be mindful for insight purposes of what the prompting event was to needing the self-soothing, which skill did you reach for, what was the outcome? Like maybe you have access to these things because I make sure of it. You utilize them, but it doesn't work as effectively as you wish it did. And I might use a thermometer or a number system like a Likert scale of like on a scale of 0 to 5, how are you feeling? Then you reach for the skill. And then what was your number at the end? um, for tracking and future discussion. So here's a picture of some of the items that I might use in a coping kit. I get everything from the dollar store, so it's reasonable for me. And also, I'm only giving them one coping kit one time. Obviously, they now know I have bins of goodies hidden in my closet once I pull them out for this first time. So they might come in and be like, I ran out of this. Did you go to the dollar store? And depending on, how often they're taking advantage of this, I'm typically letting them go in. I'm like a dentist. They're getting a prize if they've done a really good job at the end of a session. But here's, just the bright colored firework papers in the left hand side vertical image in the center are great for cognitive behavioral therapy if you're writing down a thought challenge or a distortion you want to collect in big marker letters on big bright rainbow things that they can put on their nightstand or on their door or in their backpack or on their bathroom mirror. You've got all kinds of things that make sounds, that are sticky, that smell different, glow sticks for light. You see the warheads and the fireballs. Mints can be really helpful. I mentioned that I usually have um, journals on hand for clients. So I found this one that said clear the clutter. Um, if temperature is something that's really helpful, I just found these like beaded masks on the bottom right that clients can put in the refrigerator. So if they're somatic and they're getting headaches when they're really anxious, they can utilize those. It's just a redirect to temperature on a part of the body that can sometimes just be soothing on its own. I have a lot of clients that cry in an effort to cope with their anxiety. It just like comes out, and sometimes it feels really helpful, and sometimes it feels, they don't want to. But if they're feeling really puffy, they can also use those eye masks, shower steamers, bath bombs. Again, all the stuff I got at the dollar store. Totally up to you how much you want to sort of like invest in these little things. You could give them one like piece from every sense if you wanted to, just to get them started so they could practice engaging in the five senses, seeing which of the five senses is most effective for them. And then that's really great information for both of us so that we can prioritize skills that utilize and lean into that particular sense. So I'll know if they're a visual person, if sound is most effective, if incorporating some sort of tactileness is going to be best for their coping. So it's an opportunity to sort of equip them with something they can reach for in the moment. We usually put it in like a little bucket or bowl that they bring home. We strategize together before they leave where they typically encounter stress. And if you like do get overwhelmed at the family dinner table or where you do homework, that's where it lives. If you have a hard time falling asleep because you're so stressed out about the next day and that's when your mind starts to run, that's where you put it. Um, and you can break it up. You can have it in different places. You can put a little one thing in the car if driving in a car makes you car sick and nauseous and that amps up your anxiety. You could have something at school. It's a little bit of trial and error, but it gives them something that they can literally reach for that they're equipped with, because for minors especially, they're not necessarily going to go for that cognitive skill right away. They're going to go for something they can reach for. Somebody brought up that their practice is fully remote. Maybe they could make a shopping list for those and suggest the dollar store. I think that's a great idea. Um, Depending on how far you are from people, you could always, I had to be kind of creative um, with people in like during the pandemic when I couldn't see them. So like leaving a little basket in front of my office if they like wanted to drive past it, they could pick it up. Um, Things like that. But I think having like a picture and a list of things could be a really great idea. And it can still be like a fun activity you do with them. Also for temperature and for like skill use, not just for minors, but for any client, cool down cubes, these reusable ice cubes, which a lot of my clients who are anxious report getting hot. Um, so having something cool can be really helpful. And ice is great, but sometimes it stings a little bit. People are sensitive to that and then melts. And that's also something that they don't necessarily want. So you can put these reusable ice cubes, which are fun colors, which also taps into sort of that visual aspect, to fill with water. So it makes that like taps into that auditory aspect. And they're see-through. So you can write cues to prompt additional skills on the cubes when they reach for them. So they're not only getting that temperature distraction, which they might need in distress tolerance, just like immediately redirect from that distressing thought. Um, and then they're looking at it and they're looking at a self-soothing thing or mindfulness or, whatever skill you want. Multi-purpose, big fan of cool down cubes. And again, not just for anxiety. If someone's sad, this can be really helpful. If someone's really irritable, that can help. Imagery, we think of mental images as having the ability to control physiological responses. When we think of stress, we think of increased adrenaline, muscle contractions, increased heart rate. And the opposite is true for imagining a safe or calming place. That could be at the beach, cabin in the woods, a family cabin, depending on what the client prefers. And when you have them bring up imagery in session, I encourage you to sort of have them describe each of the five senses, because that creates depth to the imagery and it makes it more likely that it'll be available and accessible to them to reach for it when they're overwhelmed. So if you're thinking about the beach, like what did it smell like? Oh, it smelled like salt or sunscreen. I could feel the sand underneath of me. I could hear the waves. I could see the kite flying around, just building out different things so that it's not just like, oh yeah, that beach, build into it a little bit more. That depth will be really helpful later on. And what's great about imagery is you can carry that relaxing place with you wherever you go, and no one's going to notice that you're utilizing that distress tolerance skill because it's in your mind and we are not readers. So I do like this model of emotions from the manuals. I use this a lot. I have printouts of it that I can go through with my clients because I think it's such a great way to lay it all out and build insight. And I think regardless of the training the modality you're prioritizing, this is an effective worksheet and it breaks it down into vulnerability factors, which it's not, when we think about it, it makes so much sense, but it's not necessarily something that we as individuals are considering when we're considering our day and how it went. So that's like eating and sleeping and the stresses before, that all impacts how we are doing every single day. Even the day before impacts the next day, could impact the next week. So thinking about those vulnerability factors, validating that they sort of were already set up with half a tank of gas because the day before was so rough. That prompting event, those thoughts, after effects, paying attention to the internal and external somatics, tapping into that emotion, any urges, any actions. It ties back to that triangle of CBT. So I'm a big fan of this. You could use this as like a prompt for talking through some of these things. You don't necessarily have to have them complete it, but this can be a great worksheet for them to use in between sessions if something happens and they kind of want to work through it before they get to you so that it's sort of off of their chest and they're not carrying it until they have you. But also like a learning opportunity. They can start going through it, and then with your prompting, they can make it, a more depthful exploration. So I'm a big fan of the model of emotions with DBT. When I think about vulnerability factors, I'm always assessing for eating habits and sleep hygiene. And when I talk about sleep hygiene, talking about that set of routines that helps you sleep better, which we know is not only going to like impair or help repair that physical body, but boost immune system, help with emotional and cognitive renewal. These are all things we need to regulate effectively. So making sure their sleep routine is consistent, reducing, minimizing, and masking visual and auditory noise. Some people have a hard time with other sounds or with other light, and so problem solving that. Not everybody benefits from having a cooler temperature. And some people like to make it cold in the room, but then wrap themselves up. So assessing their temperature preferences, informing them about the impact of nighttime food or drink, making sure that the bed itself is used for sleep and intimacy only. If a client is staying up, doing their work, sitting on their bed, that's where they're playing video games, that's where they're engaging in all of their like awake, alert activities, it's going to be harder for the body to attach that object with rest and relaxation. And so they should move. They can stay in the bedroom, but leave the bed, go to a desk, go to a chair, sit on the floor, go to the table in the kitchen, um, coach them and inform them about relaxation, PMRs, deep breathing, stretching routines. This could be 5 minutes of their time. It doesn't have to be a big one. Inform them about the 20-minute rule. If they are laying in bed awake and they can't fall asleep, they don't fall asleep, then get up, leave the bed, walk around the room, leave the room if that feels better. Do that for a few minutes. Very likely the body and the brain are just not communicating effectively in that moment. And they will catch up to one another. They will realize it's 1 o'clock in the morning. They have yet to fall asleep. They're tired. So when they feel sleepy, return to bed. Because again, you don't want to associate the bed with wakefulness. Um, when I think of interpersonal effectiveness, I think of validation. And I was reading during one of the breaks about someone who felt like CBT could be thought of as invalidating to a client because of their past experiences. And that's where their distorted thinkings are. And like those things are sort of like keeping them safe 100%. Again, not all of these tools and techniques are going to be applicable to every client. So it's important to get to know them. And we'll kind of go through very quickly the difference in presenting concerns and what would be best. But you want to make sure that you're communicating to them what they're saying makes sense. You do that by paying attention to them, eye contact, verbal and nonverbal prompts like nodding your head, leaning forward. Oh, I see. That sounds really hard. Sounds like it must be frustrating. With the gas tank, with minor clients, being a kid is hard. You want to validate them, praise them, help them internalize that. Sometimes they're doing their best and they could probably be doing better. We can understand that through a lens of DBT, but we want to praise them for their efforts. If clients can't get out of bed, as a person working with high risk clients, as a DBT practitioner, you might be coming into contact with clients that are having a tough time getting out of bed, kind of walk them through it. Think about it. Start with sort of that imaginal exposure, visualize themselves standing up, walking around their room, using that positive self-talk. Same thing with progressive muscle relaxation. Have them start getting behaviorally activated, wiggle their toes, tense and release their calf muscles. Think about that reward that they're going to receive when they get out of bed. Move slowly, small, manageable, accomplishable steps. Hang their legs over the side of the bed. Put their feet on the ground. Literally ground them. More self-talk. Cheerleaded and modeled by you. Hopefully eventually internalized by them. Stand up slowly, walk to the reward, and praise themselves. And so I might walk a client through that because this distressing thought or feeling might be so overwhelming that they feel like they can't get out of bed. This is just a list that you can review after the training is over with just some of my favorite applications that I use with clients. What's Up is more generalized for presenting concerns. Combined Minds is more for incorporating family and friends. Calm Harm is my favorite application to use with individuals that do have urges to um, hurt themselves. Insight Timer for people who are really auditorily um, motivated, guided meditations, forums. ThinkLadder and Flowly do have subscription options. ThinkLadder is very CBT based, helps to find and challenge distorted thinking. And Flowly, as I mentioned earlier, is that biofeedback virtual reality application um, that was designed in addition to chronic pain to help manage anxiety. These are some questions you can ask yourself as you're deciding what type of modality or combination of modalities might be effective. So, what's maintaining that anxiety? Is it avoidance? Is it intrusive thoughts? Is it emotional reactivity? Are there somatic experiences? Is there avoidance? Is it more about the dysregulated emotion, which would be DBT, or distorted thinking, CBT? Are there signs of impulsivity, self-injury, or suicidal ideation? DBT might be better for that. Are they engaging in reassurance seeking or safety behaviors? That's ERP. Um, are they open to gradual exposure, or do they strongly resist discomfort? They may not be ready for ERP. Um, do they have the bandwidth to commit to, if you are a strict DBT provider, that structure and intensity, or depending on their availability and openness to participating in homework or daily skills practice? And then does their environment support treatment? We're thinking of safety, consistency, social support. So in summary, I have a text and graphic version based on, your learning style. So when I think about CBT, I'm thinking about a client that has some level of insight and cognitive flexibility, and that might be impacted by age. Um, Client is open to structured homework and skills-based work, and it's clearly linked to thinking traps and avoidance behavior. So it's much more about the cognitive aspect. ERP, there's that clear avoidance compulsion cycle. You have perhaps insight that that irrational fear is present or partially present. They are willing to engage in some short-term distress for long-term gain. And maybe other modalities haven't really resolved that anxiety loop. And for DBT, I think of high-risk behaviors, self-harm, suicide attempts, suicidal ideation, and that emotion regulation challenges are essential, as that is one of the primary modules of DBT. So then when I think about, these other graphics, this is just another way to look at it with evidence for these particular types of diagnoses for CBT, DBT, and ERP, and limitations. CBT is less effective for that severe emotional regulation or insight. It does require some cognitive engagement. That DBT modality is very resource intensive. Group availability is sometimes limited. There may not be local groups available to you, and they're only accepting so many, caregiver client dyads. And that rigid structure may not fit everybody. And ERP is emotionally intense. It's not ideal for trauma or for poor insight. And without that psychoeducation that we talked about, there is a high risk for, dropout. These are some references you can check out later. I have some questions queued up. I'm not sure if anyone else has questions in addition to that. I'll get to some of these questions and then turn it over to Bonnie to wrap up. But I really deeply appreciate all of you being here, having the opportunity through Agents of Change to present to you. Your participation has been great thus far. So let me see. I think I already addressed a little bit that clinical opinion about the possibility that CBT could at times be invalidating for clients if sort of they're coming from a chaotic or unjust environment. Absolutely. I think we aren't necessarily invalidating the cognitive distortions. We're initially working to really understand them, to build that insight, to validate what drove that distortion to be internalized. So in that way, we are sort of in theory validating that but they might not be a good candidate, as I just reviewed. There's definitely things that might suggest that ERP or DBT is a better intervention for that particular client over CBT. And that's where sort of the assessment and just constantly building insight collaboratively with your client is going to allow you to make that change. So you might start with some CBT or DBT, depending on your comfort level as a practitioner, and then based on the information that they're providing to you and what is become hard and distressing for them and what their barriers are, like might allow you to sort of change course and integrate some skills from these other modalities. Because again, it's not, you could offer a strict DBT treatment, but you don't have to. It can be mended. We can create Franken manuals. You can be flexible with it. Let's see. Someone asked about postpartum depression and CBT and cognitive restructuring as being most effective. I don't have any experience with postpartum depression, so I definitely encourage you, to seek out specific training with postpartum, as there are, maternal and parental postpartum specialists that would probably have much more insight and experience into that. But again, you're sort of working with the same idea. You're just giving them the space to process the fears that they have, their cognitive distortions that they have. You're wanting to understand for yourself, but also for them, where that distortion came from. Remind them that that is the lens through which they're looking at a lot of things, collect evidence that's the contrary, and think of a different way of them to think about that feeling or that behavior so that it feels more manageable and tolerable. Um, let's see here. I'm going to go to, I appreciate all of your feedback. I'm so happy to have everybody here.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.